Welcome to the Deep Dive. Today we're tackling something really fundamental to all of medical practice. How doctors actually make decisions. It seems, pretty straightforward on the surface.
But it's really not. It's this fascinating, surprisingly complex landscape,
Huh.
full of probabilities, uncertainties, and just the constant challenge of becoming a truly effective physician.
Exactly. Because at its core, medicine is about choosing the best path forward when the answers aren't always, crystal clear.
That's right. And our source material starts us off with a great quote from Sir William Osler. He said, "Medicine is a science of uncertainty and an art of probability."
That really hits the nail on the head, doesn't it?
It absolutely does. It highlights why just, memorizing facts isn't enough, that knowledge is just the foundation. True mastery is built on top of that.
Right. You can know all the biology, all the surgical techniques, but when you're faced with a real person, with their unique, often confusing mix of symptoms, that's where the real challenge, and maybe the art part, comes in.
And we also have to remember the sheer explosion of medical information recently. I mean, it's just overwhelming compared to even a generation ago.
Oh, absolutely. The constant flood of new research, new tests, new treatments, it's almost dizzying keeping up.
Precisely. And our source makes the point that today's physicians need a much broader, more sophisticated skill set to really excel.
So that brings us to the core of our discussion today, then.
Exactly. We're going to delve into what our source identifies as the three crucial pillars of the modern medical craft. First, there's clinical reasoning, basically, how doctors think.
Okay.
Then, the rational use and interpretation of diagnostic tests. And finally, the principles of evidence-based medicine, or EBM.
All right, let's dive into that first pillar. Clinical reasoning. We all kind of picture that great doctor, right? The one who just seems to figure things out brilliantly.
The diagnostic wizard.
Yeah. But the source points out that defining clinical expertise is actually really elusive, like trying to catch smoke. We recognize these clinicians, the ones with that special problem-solving prowess.
But even they often can't really articulate how they do it. It's almost instinctive for them at a certain point.
And it's not like it's a general skill either, is it?
No, that's another key point. The source stresses that this kind of virtuosity isn't necessarily transferable. Someone brilliant in, say, cardiology might be totally lost with a complex neurological case.
Right. It's very domain-specific. And expertise isn't just thinking either.
No, not at all. Our source reminds us it's a whole package. There are the cognitive parts, the disease knowledge, picking up cues, interpreting tests, all that.
Sure.
But also fine motor skills for procedures, crucial communication abilities, and coordinating care. It's a complex blend.
But the research is mainly focused on the thinking part.
Mostly, yeah. Probably because studying the cognitive elements, while hard, is maybe more tractable than objectively measuring, say, communication skill or manual dexterity. Researchers use things like think out loud protocols.
Where doctors talk through their reasoning as they work.
Exactly, but that only captures so much. And a lot of the research has, understandably perhaps, focused on identifying errors, trying to figure out where the reasoning goes wrong.
Which makes sense. Learning from mistakes is vital. But you're saying there isn't one single theory of clinical reasoning.
No, not really. Our source highlights that different fields, cognitive psychology, medical education, even behavioral economics, all contribute perspectives. But they often use different language, different frameworks, even when talking about similar ideas. There's no single unified model yet.
Okay. So one big framework is this idea of two systems of thinking.
Yes, the dual process theory. It's very influential. It suggests we have, broadly speaking, an intuitive mode system 1 and an analytic mode system 2.
System 1 being the fast gut reaction kind of thinking.
Right. Quick, effortless judgments based on learned associations and heuristics, those mental shortcuts or rules of thumb. The example given is black woman plus Hiller adenopathy equals sarcoid. It's rapid pattern matching.
Like a mental reflex based on experience.
Pretty much. And system 2 is the opposite, slow, methodical, deliberate, effortful reasoning. Like a student painstakingly listing all the causes of Hiller adenopathy and systematically investigating them.
So intuition versus analysis.
Well, they're really ends of a spectrum, a cognitive continuum. And they interact in complex ways. It's not strictly one or the other.
But this model doesn't tell us how to get better at reasoning.
Not directly, no. The source points out it's more descriptive than prescriptive in terms of developing expertise. It tells us how we think, but not necessarily how to improve that thinking.
Okay. Let's talk about pattern recognition. That feels very much like that fast System 1 thinking.
It is. And it's described as complex, yet seemingly effortless when it works well, like recognizing faces or musical styles you just know.
And experienced doctors build up this huge library of patterns.
Exactly. They've seen so many cases, they can rapidly recognize familiar diagnostic patterns. It's like having a vast internal database of clinical pictures.
But if you're a student or even an expert facing something new,
Then you have to rely more on that slower analytics system too. You don't have the pattern stored yet.
the source gives those examples with hemoptysis, coughing up blood.
Right, great examples. A young non-smoker with a cough and a bit of blood. Pattern suggests simple bronchitis.
But the same symptom in an older smoker with weight loss.
Instantly triggers a different pattern, potential lung cancer.
And the third one, the immigrant with a murmur, coughing blood.
Flags another pattern, maybe pulmonary hypertension from rheumatic mitral stenosis. It shows how context and associated features instantly shape pattern recognition.
But you can't just rely on patterns alone.
Absolutely not. That's a critical warning. Relying too heavily on pattern recognition can lead to premature closure.
Meaning jumping to a diagnosis too quickly.
Precisely. You see a familiar pattern, you lock onto it, and you stop thinking, stop gathering more information, potentially missing the real diagnosis.
Like that sobering example of the 45-year-old man.
Yeah, the one with flu-like symptoms who actually had a heart attack, an MI.
The clinician saw a common pattern, used a standard checklist for a respiratory infection.
And completely missed the crucial details about the exertional shortness of breath because they'd already mentally closed the case. A devastating outcome from premature closure.
Wow. Okay, so that highlights the dangers. And this connects to heuristics, right? Those mental shortcuts.
Yes, exactly. Heuristics are the tools of System 1. Super efficient most of the time, but they can lead us astray if we misapply them.
And there are different ways researchers look at these.
Right. There's the Heuristics and Biases program, which really focuses on how these shortcuts lead to systematic errors, cognitive biases. They've identified like over 100 of them.
100 biases, that's a lot.
It is. But interestingly, the source notes that just teaching doctors about these biases doesn't seem to reliably reduce diagnostic errors in practice.
Huh. So just knowing about bias isn't enough to stop being biased.
Apparently not, or at least it's not that simple. Awareness doesn't automatically translate into correction in the moment. Then there's the Fast and Frugal Heuristics program, which looks at how simple rules can actually be surprisingly effective and adaptive in certain environments. It's a bit more nuanced.
Okay. The source highlights 4 key heuristics relevant to us here. First, representativeness.
Yes. That's diagnosing based on how closely the patient matches your mental picture, your prototype, of a disease. It's pattern matching again.
But the risk is.
You might overestimate rare diseases if the patient looks like the textbook case, like the pheochromocytoma example, classic symptoms. But the condition is very rare compared to simple hypertension.
And you might miss common diseases presenting atypically.
Exactly, because they don't fit your representative picture. You always have to consider the base rate, the prevalent.
Okay. Second heuristic, availability.
This one's about judging likelihood based on how easily examples come to mind.
So memorable cases stick out.
Right. Really dramatic outcomes or cases you saw very recently, they become available in your memory and can disproportionately influence your judgment, even if they're statistically rare. That missed MI with painless dyspnea might make you overthink MI in the next patient with shortness of breath.
The vividness or recency makes it seem more likely than it is.
Precisely. Then number 3 is the anchoring heuristic. Stickiness.
Latching on to the first idea.
Yeah, anchoring on an initial piece of information or diagnosis, and then failing to adjust enough when new data comes in, even contradictory data. Like sticking with a high suspicion of coronary disease even after a negative stress test.
You're anchored to your initial impression.
You are. And the fourth one is the simplicity heuristic, or Occam's razor.
The simplest explanation is probably the right one.
That's the idea. And it can be helpful, but our source warns there's no biological law guaranteeing simplicity in medicine. The big risk here, again, is premature closure, settling on the simplest fit and ignoring other findings that don't quite line up.
Okay, so when intuition and heuristics might fail us, or the case is really complex, we shift to System 2, the analytic mode.
Right, and a key model here is the hypothetico-deductive approach.
Which involves steps.
Sort of. First, hypothesis generation, creating an initial list of possibilities based on the presenting problem.
Like a differential diagnosis list.
Exactly. Then, diagnostic refinement. As you get more information, like from the patient's detailed history, you update the likelihood of those hypotheses. Some become more likely, some less.
Then the physical exam adds more data.
Right, helping you further narrow things down. And the final stage is diagnostic verification checking, if your leading hypothesis really explains all the findings coherently.
And negative findings are important too.
Hugely important. The absence of a key symptom or sign can significantly lower the probability of a diagnosis. Like chest pain not related to exertion makes typical angina much less likely.
Makes sense. And you also have to consider urgency.
Absolutely. Those diagnostic imperatives, conditions that are rare but catastrophic if missed, like aortic dissection in severe chest pain. You have to think about those, even if they're statistically unlikely.
Whereas in less urgent situations, prevalence plays a bigger role in that initial list.
Yes, the base rates become more relevant for guiding your initial hypotheses.
So what makes the experts different in their reasoning? It's not just that they use System 2 better, is it?
Not entirely. Experts are incredibly efficient. They chunk information in working memory, which has limited capacity. Those cognitive shortcuts, heuristics, and pattern recognition are actually crucial for them to quickly generate relevant hypotheses.
So they use System 1 very effectively too.
Very effectively. And research has shifted focus a bit from just the process of expert thinking to how their knowledge is organized.
How so?
Experts build up vast stores of things like exemplars, vivid memories of specific past patients, and prototypes, more abstract models of diseases, including typical features and likelihoods.
And illness scripts.
Right. These are like organized knowledge packets linking risk factors, pathophysiology, symptoms, signs, the expected course. Experts have more of these scripts, and they're much better connected and easier to access.
So it's about the richness and organization of their knowledge base.
And their ability to make powerful distinctions, knowing the key features that separate one diagnosis from another in a specific context. It's not just memorization, it's about accessing the right information at the right time.
And maybe future electronic tools could help leverage collective experience.
That's a potential future direction mentioned. But for now, how do we train expertise? The source is a bit uncertain about whether traditional teaching can accelerate it much.
More about practice and feedback.
Seems likely. Deliberate practice, coaching from mentors, that seems key. Exposing trainees to lots of patterns and differential diagnoses is helpful, as is encouraging active learning, like metacognition, thinking about your thinking and following up on outcomes.
Got it. Okay, let's shift to the second pillar. Diagnostic versus therapeutic decision-making. There's a big push for personalized treatment now.
There is, and the source breaks that down into two main ideas. First, individualizing risk and benefit assessment using patient characteristics. That's precision medicine.
Tailoring the science to the individual.
Right. And the second part is incorporating the patient's own preferences and values. That's shared decision-making.
So it's not just what the science says, but what matters to the patient.
Exactly. Finding the path that aligns with both the evidence and the patient's goals. But there's a caution here.
About relying on personal experience.
Yes. Our own experience is usually too small a sample size to reliably personalize evidence, especially for rare events. You can easily be misled by anecdotes.
So we need larger studies for effectiveness.
Generally, yes. Therapeutic effectiveness often only becomes clear in large populations. That's why clinical trials and big outcome studies are so crucial.
And guidelines try to synthesize this, but aren't always one size fits all.
Correct. Guidelines are vital, but good clinicians know when individual factors warrant deviation. Research is increasingly looking at this heterogeneity of treatment effects and using risk scores to help tailor recommendations.
Okay, pillar 3. Non-clinical influences. It's not all pure science driving decisions, is it?
Definitely not. The source outlines 3 big categories. Factors related to the individual doctor, the practice setting, and payment systems.
So individual factors.
Yeah.
Like the doctor's knowledge.
Yes, their knowledge, training, experience, all crucial for being a good patient advocate, but also their practice style.
How they tend to do things based on their background.
Exactly, like the example of cardiologists favoring stress imaging for low-risk chest pain versus internists maybe starting with an exercise ECG. Different training, different norms.
And then there's defensive medicine.
Right. The fear of malpractice suits driving overuse of tests or therapies that might have low benefit just to cover bases legally, like maybe routine annual stress tests in people with no symptoms.
And the practice setting itself matters too.
Hugely. Workflow, technology, organizational culture, even the physical environment. There's also this idea of physician-induced demand.
Using resources just because they're available.
Kind of. The availability of specialists or high-tech facilities locally can influence utilization. And fragmentation of care, seeing multiple disconnected providers, can also impact decisions.
And finally, how doctors get paid. That must have an effect.
Oh, absolutely. Economic incentives matter. Fee for service, where you get paid per item, can encourage doing more, potentially overuse.
Whereas capitation, a fixed fee per patient.
Might encourage more focus on population budgets and reducing low-value care. Salary might disincentivize seeing huge volumes. It's complex.
And the shift to value-based payment tries to fix this.
That's the goal: align payment with benefit and reduce waste. But defining and measuring value effectively is still a major ongoing challenge.
Okay, let's circle back to diagnostic tests and interpretation. Even with amazing technology, uncertainty remains, right?
Absolutely. And it's often compounded by information overload. Clinicians are drowning in data, trying to find the quality, relevant bits.
Computers might help eventually, but for now.
For now, a solid grasp of how diagnostic test information works is fundamental. And remember, a test is really any information that changes your assessment history, exam findings, not just lab results or images.
We often simplify results to positive or negative.
We do. It loses some nuance, but it helps grasp the principles. To evaluate a test, you compare it to a gold standard in a representative population.
Avoiding bias in that comparison is key.
Crucial. You need the right population and accurate gold standard results for everyone. Then you calculate those 4 key measures.
Sensitivity and specificity.
Right. Sensitivity is the true positive rate, how well the test picks up the disease in those who have it.
And specificity is the true negative rate.
Correct. How well the test correctly identifies those who don't have the disease.
And the flip sides are false negatives and false positives.
Exactly. False negatives are people with the disease missed by the test. False positives are healthy people incorrectly flagged by the test.
Ideally, both sensitivity and specificity are 100%.
Which is rare in reality. The mnemonics are helpful here. Send out high sensitivity, negative result helps rule out disease. And SOP in high specificity, positive result helps rule in disease.
And the cut point you choose for a test result matters a lot.
Tremendously. Where you draw the line between positive and negative directly trades off sensitivity against specificity. A stricter cutoff improves specificity but lowers sensitivity, and vice versa.
You can visualize this trade-off with an ROC curve.
Yes. The receiver operating characteristic curve plots sensitivity against 1 specificity for all possible cut points. The area under the curve, the AUC, quantifies the test's overall discriminatory power. 0.5 is useless, 1.0 is perfect.
And choosing the best cut point depends on the context.
It does. It depends on the harms of false positives versus false negatives, and sometimes even the disease prevalence.
Okay, so how do we use this information to update our thinking? That's Bayes' rule.
Exactly. Bayes' rule is the mathematical way to quantify how a test result should change your probability estimate. It connects the pre-test probability, your belief before the test,
Based on prevalence or the clinical picture?
right, to the post-test probability, your belief after the test result, incorporating the test's sensitivity and specificity.
The source warns about using predictive value loosely.
Yes, because positive predictive value, the chance someone with a positive test actually has the disease, is heavily dependent on the pre-test probability or prevalence. It's not an intrinsic property of the test itself. Post-test probability is a clearer term.
Likelihood ratios are another way to apply Bayes.
They are often used with nomograms. The likelihood ratio for a positive test, LR+, tells you how much a positive result increases the odds of disease. And LR+ over 10 is generally considered strong evidence for the disease. That Spiepen Red's an idea again.
And the likelihood ratio for a negative test, LR.
Tells you how much a negative result decreases the odds. A very low LR, say below 0.1, provides strong evidence against the disease endnote.
Let's apply this to CAD testing, a standard treadmill test.
Has moderate sensitivity and specificity, maybe around 60% and 75%. That gives an LR plus of only about 2.4. It increases suspicion, but not dramatically.
Whereas a SPECT perfusion scan is more accurate.
Generally, yes. Sensitivity and specificity often around 90%. That gives a much higher LR plus of about 9.0. A positive result there provides stronger evidence for CAD.
But even the better test might not change management.
Exactly. A positive SPECT in someone with very low pretest probability might still leave them in a low-risk category overall. Specificity is really key in low-prevalent screening settings to avoid false alarms. Think HIV testing in blood donors.
And conversely, a negative test in someone with very high pretest risk might not rule out the disease if the test isn't sensitive enough.
Correct. The biggest impact of testing, the biggest change in probability, usually happens when the pretest probability is intermediate, maybe in that 30–70% range.
And we need to remember the simplifications, right? Tests aren't always just positive, negative. Results aren't always independent.
And sensitivity specificity can even vary depending on disease severity or the population tested. A treadmill test performs differently in someone with mild versus severe CAD or in inpatients versus outpatients.
Which leads us to statistical prediction models, taking multiple factors into account.
Yes, multivariable models like logistic regression can weigh various patient characteristics to give a more refined probability estimate, like for CAD risk.
Strength is accuracy, weakness is complexity.
Right. You usually need a calculator or computer. We're seeing more use of guideline-based online tools like the ACH cardiovascular risk calculator or CHA2 DS2VASE for AFib.
But integrating these seamlessly into EHRs is still evolving.
It is, and importantly, not all prediction models out there are well validated. You need independent validation in different populations before trusting them fully. Unvalidated models need skepticism.
How do these models compare to clinician judgment?
Studies show models can be more consistent, especially for survival predictions, but not always more accurate. And for diagnosis, experienced clinicians still tend to outperform current apps or websites.
But they can still be useful for learners.
Definitely. Decision support could help broaden differentials for trainees or prompt reconsideration if things don't add up.
Which ties into decision support systems generally. Been trying this for decades.
About 50 years, yes. Support can range from simple information access to outcome prediction to algorithmic guidance.
But the AI systems that truly replicate reasoning are still limited.
Success has been limited so far. IBM's Watson is often cited as an example where early hype didn't fully translate into widespread clinical adoption.
What has worked better?
More basic things integrated into EHRs, reminders for drug interactions, prompts for guideline adherence, maybe computerized protocols, and checklists seem promising for reducing certain types of errors.
Okay, what about decision analysis? That sounds more formal.
It is. It's a normative approach, often used for complex policy decisions where you need to systematically weigh pros and cons under uncertainty.
Like the breast cancer screening example.
Yeah.
Analyzing different start ages and frequencies.
Exactly. The CI-SNET analysis used modeling to find the most efficient strategy, biannual screening for average-risk women. It helps structure thinking when you don't have direct RCT evidence for every specific question.
But less useful for real-time individual decisions.
Its direct application in that setting is often less clear, more complex.
Shifting gears slightly, diagnostic errors are a serious issue.
A very serious issue. Estimates suggest they're quite common, and the thinking is shifting from blaming individuals to looking at system flaws. Most people will likely experience one in their lifetime, potentially with bad consequences.
And solutions involve systems. Decision support, EHRs.
Yes, system-level changes are key. Checklists are proposed for cognitive errors like premature closure, but the evidence for them preventing actual harm needs to be stronger.
All right, let's tackle the final pillar, evidence-based medicine, EBM. This updates traditional practice.
It does, by emphasizing a systematic process for using current research. It involves 4 steps. Frame the question, find the evidence, appraise the evidence, and apply it to the patient.
Finding and appraising sounds time-consuming.
It can be, and requires skill. That's why systematic reviews are often used as a shortcut.
Comprehensive summaries of evidence on a topic?
Exactly. Done rigorously to minimize bias. The Cochrane database is a key example. Meta-analysis is often used within these reviews to statistically combine results from multiple studies.
But systematic reviews aren't perfect either.
No. Their quality varies, and they can't fix bad primary research. You still need to use them critically, maybe look at key original studies too. The literature is flooded with reviews now. Not all are great.
So where does the primary evidence come from? Trials and registries.
Primarily, yes. We've always learned from observation, but turning that into reliable evidence is the tricky part. Think of all the confusing observational data during COVID-19.
Small observational studies have limitations.
Big ones, validity, generalizability. So randomized clinical trials, RCTs, and high-quality observational registries are the main tools now.
Registries track real-world data.
Yes, on diseases, procedures, etc. Observational data, whether prospective or retrospective, is valuable because it reflects broader populations and situations where RCTs aren't feasible. But the big drawback is potential treatment selection bias.
RCTs avoid that bias through randomization.
Yes, random allocation balances known and unknown confounders. But RCTs can have their own issues, like limited generalizability if the participants are very select, or if the control group isn't appropriate, like placebo controls for drugs expected to be better than existing treatments. Quality varies a lot.
And meta-analysis combines these studies.
Right. Quantitatively combines results, ideally from unpublished RCTs using individual patient data to avoid bias. But again, the meta-analysis is only as good as the studies it includes.
But it can find signals missed by smaller trials.
Yes, like the early streptokinase trials for MI, but it's not a magic fix for poor data. We look at relative benefits, odds ratios, relative risks, but also absolute ones.
Like absolute risk reduction, ARR, and number needed to treat, NNT.
Exactly. NNT, which is 1 divided by ARR, gives an intuitive feel for treatment efficiency, how many people need treatment to prevent one bad outcome. But you have to interpret NNT carefully. It assumes homogeneity, depends on follow-up time, etc.
In clinical practice guidelines, pull all this together.
That's the goal. There are systematically developed statements to assist decisions based on EBM principles, literature search, evidence review.
Focused on specific conditions or interventions.
Right. Aiming to improve quality by identifying best practices. But they're meant to assist, not dictate. Expert panels write them, but expertise can vary.
And they rate the evidence quality.
Yes, they include recommendations, evidence ratings, benefit harm assessment, and discussion. Importantly, many recommendations are still based on expert consensus because high-level evidence is often lacking.
So not everything in a guideline is based on strong RCTs.
Often, only a small proportion is based on the highest level evidence. Peer review is the final step, and guidelines are increasingly linked to quality measures.
So wrapping up this deep dive, EBM gives us great tools, but not finished answers.
Precisely. It's a framework, an ideal. We always have to remember individual patients might respond differently than the trial average.
And much of medicine won't ever be tested in big RCTs.
That's the reality. So excellent clinical reasoning, drawing on experience, using quantitative tools wisely, and deeply understanding patient preferences, those remain absolutely essential for the foreseeable future.
Couldn't agree more. And maybe a final thought for you, our listener. Think about how that balance between your own intuitive, fast thinking and your slower, analytic reasoning shifts as you gain experience. And maybe more importantly, what specific strategies can you consciously use to try and catch the biases that can creep into both ways of thinking? Something to definitely mull over.